Yeah, that's my sick tune. Since February 2003, this has been my sick tune. If you don't know, it's called Together Again by Dave Cause. And each and every Sunday we come together again under the umbrella of Ultimate Health. The ultimate guide to healthy living. Take my praise from Eternal, B.B. Winans. I wanna be the only one. The ultimate guide to healthy living, this and every Sunday, 2:05. Indeed, we are alive.
Joy 99.7 FM.
Okay, last week, on the heels of World Pediatric Surgery Day, we sought to celebrate the expertise, the specialty. Today I give you a double dose. Still in the studio with me, I have Dr. Wilfred Kojo Asman, pediatric surgeon with the University of Ghana Medical Center. School always comes. And next to him, I have Dr. Victor Etre, consultant pediatric surgeon, president of the Ghana Association of Pediatric Surgeons. If they had an anthem, I'll play it. But we're going back into pediatric surgery, that area of specialty that tells us that, look, when we are conducting surgical interventions for children, we need a whole new cadre. Specialized tools, tools, operations, awareness of the developmental stage, the physiology of the child. We talked last week about different needs when it comes to the anesthesiology of the child and all those manner of things. They are back today to feed us on that. So that's why I got them this Sunday, and we're delving back into pediatric surgery. Docs, you're welcome.
Thank you.
Right. One of the mics is a bit. Take that again.
Thank you very much.
Yes.
Thank you.
Oh, good. Today we have you live. Dr. Trey, it's been a while.
Yes, it has, Nortey. It's
Charlie.
been ages.
Ages. But you're still in the system.
You have also been in the system.
Oh no, now I'm out. I'm comfortably retired. But I know academically you're teaching, you're still doing surgery and all that.
Yes.
Wow.
Very much so.
How many years?
I do a lot of surgeries. My primary facility is Kolebu Teaching Hospital.
Of course.
Where I do most of the surgeries, and more than just what meets the eye as surgery, I also do endoscopies.
Wow.
And then
every
week, yes, in Kolebu.
With Nyama?
Yes, Nyama is
cool.
a very good friend.
Yeah.
Yes. So, apart from Kolebu, I also do surgeries at Children's Hospital, Princess Marie Louis.
How can you do
Children's Hospital.
You do Kolebu,
yes,
a premier tertiary facility.
That's right.
To say you do surgeries there is already a headache.
Well,
PML.
yes,
You're doing endoscopy.
I do general surgeries at Princess Marie Louis
Goodness
Hospital.
me.
Yes.
But you comfortably surgically skipped a question I asked. How long have you been doing this? How long have you been working?
I didn't hear that question.
You said you surgically skipped it, but for the benefit of my listeners, yeah.
Okay, so I've been in pediatric surgery unit since 2003.
You heard me say Ultimate Health started February 11th, 2003. This man has been doing surgery. Congratulations.
Thank you very much.
And I'm honored to have you
That's
alongside.
my boss.
That's your boss.
That's
your boss.
I also have
my
a boss.
Yep.
Not in addition to bridge the gap, I also do surgeries in Cape Coast.
Yes.
So it's not about me.
Do you have a drone? Do you have a helicopter? I mean, I do this to get my listeners to appreciate, right? Because people are driving by road, no police siren, nothing. No. And they are rendering these services. Other people, just between some office in Accra and maybe Spintex, noise. I'm serious, right? These are the people I want to, and I've for several years celebrated. Because if a surgeon, and they are few, leaves Kolebu to go to Cape Coast to undertake the surgery we are going to talk about. I recall when we lost our 3 urologists.
That's right.
Right?
Right.
Through again a road traffic accident. So I make you let me cut it there before you add that you go to Axim and do surgery. But
so there's a plan to try to add Takoradi. To see whether we can get there once if Yokwanta is able to, and that is something that we are.
I'm qualified. I'm qualified to say you guys are mad, right?
Joy 99.7 FM.
Because you see, the dream, the vision, the patriotic service is critical. Because if you were chasing money last week, the whole station was drenched with the fact that Dr. Asman loves his job more than money. Dr. Abubakar,
Samira
Abdullah, the praise was there, right? But we'll focus on the specialty and then how you're seeking to extend it. So you're welcome. Last week we, examined and defined the service and the specialty. Just let's touch on that again. Since your boss is here, but you want your boss to do it.
Okay. All right. So to talk about it again, pediatric surgery is a surgery for children. And when we talk about children, we starting from children that are sometimes right from the womb.
Last week, somebody sent me a message and wanted me to explain or push you guys further. When you say you're doing surgery in the womb, right, in utero, just explain.
All right. So there are certain situations that happen that a baby's formation may have a problem. And when that happens, pediatric surgeons are the ones that, together with the obstetrician gynecologists and the team, anesthesiologists and all of that, sometimes an intervention has to be done.
Baby has not been born yet.
Hasn't been born.
In the womb, in utero.
In
right?
utero.
Yeah. Right.
So there are certain situations that we may need to put in some interventions before the child is born. Sometimes we may need to actually get the baby out, even though we haven't really mastered those areas in our environment yet. We are going on to those areas. And once you bring the baby out, you can bring the baby out, do the kind of surgery you want to do or the little intervention you want to do, and put the baby back for the baby to be, to grow further and be born. And sometimes you have to do it right before the birth of the child, or once the child is born, even before the cord is clipped off. You do that before the child is taken off. So these are surgeries that we can do all the way before, the child now is really born.
Let me push a button here and ask you, when you say we can do, have we been doing them? Are we able to do them in Ghana, right? Some of these in utero, critical, complex, complicated surgeries at these early stages. Are we able to do it? I know last week we focused on the kind of specialized equipment that you need and all those things, but let's let listeners know, are we able to, are we capable, have we done them, have they been successful? Because you guys walk around and you don't say anything about your successes, right?
No, so as far as in utero surgeries are, we are not doing that here yet. There are few interventions that our colleagues in obstetrics are able to do. Let's say if a baby has too much fluid because of a problem with swallowing whilst in the womb, they're able to release some of the fluid so that the baby is comfortable and all that. As far as, let's say, baby, we anticipate that he's going to have a problem with breathing when he is born. We're able to, just at the time of delivery, we're able to do some intervention. So the delivery is controlled. We take over the breathing, system, and then the baby is delivered, so that the challenge where the child is born and cannot breathe and is likely to suffer asphyxia and all that is averted. So we're able to do those, but we need training, facility, and all that. But with regards to in utero surgery, it's not everywhere in the world that is being done.
All right, folks, if you just joined us, 16 minutes past the hour of 2 on Joy 99.7 FM. The program, as always, Ultimate Health, your ultimate guide to healthy living, this and every Sunday. If it impacts on your health and your well-being, we'll talk about it. We'll bring in the professionals, the practitioners, you name it. We got same in the studio today. We're talking with pediatric surgeons on the heels of World Pediatric Surgery Day, which falls on the 7th of April every year. We haven't celebrated it for that long, right? I think since 2000 and...
It's 3 years. So
3 years,
2020.
Okay, right. So last week also, Dr. Asman and Abdullah also emphasized the kind of, let me call it cautiously, neglect. Right? We failed to highlight these areas, and we failed to highlight the fact that children have a right. Your child has a right to specialized surgical care. Right? That is why I'm doing a second program on this, okay? So that you understand. And we also mentioned or emphasize the fact that the numbers are way below par. So there are areas in this country where a child may need life-saving, life-transforming surgical intervention, sometimes even of the simplest, most basic kind, and they do not get that. Okay, so that's why we're talking about this. If you have any concerns, questions, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. We're talking about pediatric surgery. We're celebrating the expertise, but we're also enhancing critical access and awareness. So if you have any questions, share them with us.
Joy 99.7 FM.
Okay, so we have the capacity to do some of these things. We are attracting young doctors to specialize in this area, and we mentioned last week the program being run by the College of Physicians here to enhance these numbers. But I'm going to try to delve closer or deeper into the specialty and the kind of wonders you are doing. All right, maybe to you they are not wonders because they become part of your life and your job description. But even just doing an undescended testes or hernia or whatever for a child, parents never forget this experience. Yeah. So what are the common surgical presentations? And the common are even a lot, but the ones you see a lot and typically running across from Accra, Cape Coast and whatever, what are the things you're seeing and having to quickly intervene on?
Well, so commonly the problems with children has to do in their groin, right? Okay. So we see a lot of children with hernia, both boys and girls. Sometimes mothers wonder, they know about hernia in boys, but they don't know about hernia in girls. But we manage that. We also manage a situation called hydrocele, where there is fluid collection in the scrotum. Then we talked about undescended testes. Then there is also what we call the hypospadias, in which the opening for the urine does not fall on the tip of the penis, but anywhere on the undersurface. These are quite some of the common. We've mentioned undescended testes. Right. These are quite common conditions that we see. These are the conditions when we say on elective basis. I mean, they are generally not life-threatening. Okay. When we talk about the ones that come as emergencies, then there's a mouthful one we call intussusception. Right.
Which I didn't want to have to pronounce that, so I'm very, very happy that you pronounced it.
Intussusception, and then we also are seeing quite a number of newborn babies who have blockage of their intestine. We say intestinal atresia. Wow. And the blockage can be from anywhere from the esophagus all the way down to the anus. So we see all these and quite a number.
Okay, Dr. Etche, before you move on to more, when you say something like a blockage of the intestinal passages, right, in a newborn baby, okay, let's say I was born in some village somewhere. Obviously, parents are happy, whatever we do, customary, whatever, we have a baby, right? Such a baby is there, has this. What you are describing now means, obviously, it has been detected and diagnosed, and therefore you guys can come in and fix something.
That's right.
So, in the parts where even detection, diagnosis, identification is not possible, tell me, would such a child with some of these complications die or develop abnormally and so on and so forth?
So you rightly said it. Some of these can be picked up in the womb. Okay. So that we are alerted. So generally, a lot of mothers get an ultrasound scan done while they are pregnant. And if it is well done, these anomalies can be picked up. And so there can be a referral of the mother before she delivers to a tertiary facility, so that when she delivers, there is the care. But where it is not picked up and the mother delivers, sometimes diagnosing them can be an enigma. Okay. Because if you fall into the hands of a practitioner who doesn't know anything about it, commonly they present when the child is vomiting or has a tummy that gets distended, and then they are managing for all manner of things till later. They think of the blockage and then they refer them to us.
Okay, right. Now, you mentioned ultrasound. These days, many people think of ultrasound as very, very basic and primary imaging.
Supposed to be.
It's supposed to
right. Be. Okay, so the reason I'm going back to that is that I do know from my work, and of course my late mother was a midwife, my father too, I was gynae, and so on and so forth. We have numbers. We have attendance for antenatal. The numbers change drastically when it comes to postnatal, right? Yeah. Women will see you when they are pregnant. Yeah. They'll come to hospital diligently, right? Yes. I'll leave the men out for now, right? But as soon as they've done their white and they've delivered, weighing and those things, postnatal, there's a wide variance in the numbers.
That's right.
So these are things that even if the baby is presenting these signs, already people have signed out. They're not with us.
So what sometimes, it's very Nortey, a child is born without an anus.
Mm-hmm.
Born, birth, sent home, and then sometimes 4 days when the tummy is like the mother's pregnancy and beyond, before someone detects that this baby hasn't pooped, they turn around and see that there is no opening before care is sought. So it can be really challenging. We can see them early if they are picked up early, and sometimes you can see them very late. Sometimes 10 days into life when they cannot eat anything, they are vomiting all over, they are dehydrated, not in the best of shape. Then they are coming, and it can be very challenging managing these babies.
Right. Okay. All the validation I need for this second dose of this program. But can you imagine, as a child, as an infant, 10 days, whatever, you can't speak, you can't do anything, and you were born without an anal opening, right? Okay. Your parents may not be aware, and as Doc is just sharing, well, you haven't moved your bowels, you haven't poo-pooed, you haven't done anything, but things are building up.
Yes.
Okay. So put yourself in this, position or perspective, right? It's a job even after it has been identified. Okay. But I'm just saying that, just look at this. These are people who specialize in surgical interventions for literally, well, basically for a large portion of their early development, speechless people, right? They can't complain. They can cry and so many other things. So this specialty is critical. We need to find out what is happening with your child, the child's development. Is it normal? If it's normal, we still continue to monitor it. And if there's something that needs doing surgically, these are the guys. Okay, I've got this from Prosper in Dakuman. Sunny Sunday, my good friend Nortey by nature, you never disappoint with your soothing signature tunes to invite us to your free medical consultancy. Hey, surgery in the womb, these surgeons can at best be likened to those witches in Macbeth. Hey, Prosper, fair is foul and foul is fair. Oh boy, Charlie Prosper, I'll call you after the show. We have to do lunch or something bad. Okay, you're too good. You're too good. If you want to send your 055 11 11 997, simply again. If you don't understand God, please translate to the person next to you. It means you are witches. This is witchcraft. Okay, so these are common presentations. Were there any more you wanted to add, either of you?
So there are other presentations that we see as well, apart from a lot of these congenital ones.
Okay.
There are other tumors, cancers. Sometimes non-cancers, but they are tumors. There are growths that are happening in other parts of the children that can be very dangerous. There are ones that are happening within the womb, within the abdomen, and other places that are also very dangerous, like Wilms tumors of the kidneys. You can have neuroblastomas, you have lots of different kind of tumors, rhabdomyosarcomas and so on. So there is a wide variety of things that we see in the children. Sometimes some of the children can also come in with other things that are trauma, for instance. And these are very important because trauma in children and managing trauma in children is a bit different from managing trauma in a child. A child, something that's happened to a child, the same in a car accident has happened. The child's care is a bit different from taking care of that in an adult.
Obviously.
And these are some of the things that we see.
Just listening to this. Doc.
Dr. Asma is bullying us with all this neuroblastoma and all that, but I want to also bring to light that we have other subspecialties that are also working on children. And so in the heart, we have the cardiothoracic surgeons, and there are some of them who are specialized in children. So children are born with heart problems, and they have to operate on them. Children are born with
indeed, as you mentioned that
neurosurgical problems.
When I jumped into morning show 2002, but one of the most poignant things I remember having to do was to raise money for a hole in heart case. Josephine Aipe, wherever you are, Nortey is looking for you. I know our listeners did wonders, but just as you brought that up, right? Yeah, because we had to do that, right? So you're saying that the cardiologist, for example, if he or she specializes in pediatric surgery, what we still call them cardiologists.
So he's still a cardiac surgeon, but pediatric cardiac surgeon.
Okay.
Yes, and we have pediatric neurosurgeons. And
can I count them on several hands or just one hand?
Oh,
yeah, you can count them on one hand.
You can count them on one hand.
One hand in the country we call Ghana.
Yeah.
Yes.
Goodness.
If the general pediatric surgeons are few, then you can imagine the specialties. They are fewer.
Doctors, I grew up in Kolebu.
Right.
And I remember having to have a procedure in Kolebu. But I remember a child on my ward who had hydrocephalus, right? Fluid
build up,
but a very big head.
Yeah.
Now he was in the next room, and I was so scared of him, right? And I ran around the whole ward. I was trouble, but something like that, okay. Would that fall in your lap at any point in time?
So they can be wrongly referred to us.
Okay.
But then we redirect them to the neurosurgeon.
Neurosurgeons, so, that's what I was thinking.
So hydrocephalus falls into their lap. Same as this condition where a child is born with a growth on the back. We call it the spina bifida or myelomeningocele falls in their lap.
Okay.
Yes. And there are children also with bony problems that will fall into the laps of the pediatric orthopedic surgeon.
Okay.
You know, so we have others in the subspecialty.
Okay. Yes. Right. So I'm wondering, so how does a pediatric surgeon get space and time to rest? Of course, you have your working days and so on and so on. But if I'm just looking, because years back I used to do child injuries with Dr. JPRT's late wife. She was at Princess Mary Louis, right?
Yeah.
We used to do non-accidental injury and other things, and children have swallowed crayons, they've done this, they've done that. They don't sound like life-threatening, but many of them are scary.
Yes.
All of these fall within your lap.
Yes.
Yeah?
Yes.
Yes.
Child has swallowed a coin.
So I doing endoscopies. I've taken out quite an amazing number of things. From I would say that the engine of a watch to pegs to safety pin to screw.
Yeah.
The mechanism.
Just last week we had to remove the metal within the peg.
Okay, the spring on a clothes peg.
Yes.
A child has swallowed that.
That's right.
They are wonderful people.
Wow. And you have to extract this as surgeons.
Yes.
Right?
Yes.
With obviously anxious parents.
Very anxious parents. They swallow batteries. The flat type of batteries for toys. They swallow the AAA.
Simple.
Some have swallowed the AA battery.
A child has swallowed a battery.
Yes.
If you were lucky and you were present, and as a parent you saw this, then obviously you know there's an emergency.
Yes.
Right?
Yes.
But if you were not present.
So I can give you some. Right. So I got this referral. This boy who had been sick on and off, and he was about going to Egypt for care. And the reason was because he swallowed a coin or a battery which was not detected early enough. So he had been going in and out of hospital with cough, chest infection. So somewhere in Togo, X-ray was done, and they saw a foreign body in his throat, and so they removed it. But thereafter, he developed a stricture. His esophagus got narrowed, and so he needed to have the continuity re-established, and that's how he came to me. And we've had others. We've lost. I remember one child who swallowed a coin undetected, and because I'd been in there for a long time, it created a connection between one of the major vessels in his chest, the aorta, to the esophagus. And when the coin was removed, it didn't take much time before he started bleeding into the esophagus and lost him. So they can be nightmares, really.
you're bringing back so many memories. We did some research, I remember, and I had to collect data at the accident center and other places, and I remember foreign body in throat, foreign body in ear, foreign body in this, and I remember collecting my data and remembering the kind of things that kids can get into trouble with, right? But these are I'm now, like, I can call them witches. These are the witches who take care of it. They're called pediatric surgeons, right? They're in my studio. You have any questions, concerns, share them with me. 055 11 11 997. Phone line, active. 030-221-6541. 030-221-6541. I'm speaking with pediatric surgeons on the heels of World Pediatric Surgery Day, celebrating the expertise, the specialty, and of course, enhancing critical access and awareness. That's what we're trying to do on Ultimate Health, Joy 99.7.
Joy 99.7 FM.
Okay, I think Prosper is typing again. So in these cases, a child is brought in. Obviously, the child, if the emergency and the alarm has been raised, will be anxious. Parents, anxious times, I don't know what exponential figure I will use. They are brought into you. I know we watch medical soaps, ER, and all those things. Give my listeners a picture. So this child is brought in, maybe shouting, screaming, or even just
calm,
right? Stunned, speechless. What is what do you go through? I know there's a team, right? I'm focusing on you, the pediatric surgeons, but how do you process this? And what would parents be required to understand and partner with you on?
So, as pediatric surgeons, the training gives you this ability to remain calm.
Okay.
And I mean, as much as you are calm, you are also really working very fast.
Proper calm, not that you're under the influence of anything.
No. Proper
calm. Maybe you've taken something we don't know.
No.
Okay.
Proper calm.
Professional
that
calm.
should help you to be able to allay the fears of the parents.
Okay.
I mean, whilst at the same time letting them know the seriousness of the situation to be able to act on what you really need to act on. So it's a balance.
Okay.
At the end, we are looking at getting the child to, the point that the child needs to be. What do we need to do for the child? And that is where we get to. But as we talked about last week, so the training makes it possible for you to be able to talk to the children, bring them down
on their level.
Talk
to them on their level.
Yes.
Okay.
And then also be able to bring in the parents to the level that they can be able to understand, appreciate, and help you get the things.
Sometimes the child seems to have been able to respond positively to your calming.
Yes.
But the parent, child is now calm, but the parent is now your problem, right?
Exactly.
And you're handling all of these things.
You need to. Because at the end, you need to work with parents to be able to, help you to be able to understand what you need to do, so that they can give you the consent to be able to.
That's
work
the part I'm getting to, folks.
On their children.
Consent.
Yes.
If you just joined us, 36 minutes past the hour of 2 on Joy 99.7 FM. I'm in the lovely company of Dr. Victor Echere, consultant specialist pediatric surgeon primarily with the Kolebu Teaching Hospital. He's the president of the Ghana Association of Pediatric Surgeons. He operates far and wide. Okay, let me just leave it at that. All right. Also with the college, right?
No, mine is with West African College.
West African College.
Yes.
Okay, you are those who, when we're looking for you, you're in Nigeria or somewhere else and all over the place. Right. Okay, don't tell me you do surgery in Nigeria.
No.
Right. Otherwise, government will find a tax for that. But next to him, Dr. Wilfred Kojo Asman of the University of Ghana Medical Center, also a consultant pediatric surgeon. And we're looking into this area of expertise, what is required, what kind of things they lay their hands on, if I can use that phrase. If you've had any experience, if your child has swallowed something, or you've had any reason for your child to undergo surgery, share with us. WhatsApp is 055 11 11 997. The phone line 030 221-6541, and we're live on Facebook and YouTube. A couple of messages have come in. I'll read them in a second. But docs, this business of being calm, I recall a neighbor's house help walked or ran through sliding doors. He didn't see the glass, just went through, and she was brought to my mom, who is a midwife, but the practice was like a pseudo clinic in the neighborhood, and all these cuts and things, and my mom was so calming the girl, cleaning and proceeding to suture or stitch this girl, right? And I'm wondering, so for some parents, this calm is a bit irritating, because they feel you should also show some urgency, some, I don't know whether you should be also anxious, right? There was another one where a girl was brought in and she'd been bitten by a dog. And again, the old lady went through the process calmly, and the mother said, my daughter has been, screaming at her that she should escalate a bit. Do you get these kinds of experiences?
So, in our training, we've been told about certain situations that the doctor shouldn't be calm. A bleeding patient. So if the person is bleeding, then you have to do all you can. So in that case, you have to run around, whatever. A person who is having difficulty breathing, so let's say an asthma, and it's not resolving, so you call, status asthmaticus.
Right.
A child who is convulsing, so there are certain situations that a child or a patient who is dying, where you need to ventilate, or so these are ones that you have to, run around. But as being people who watch a lot of movies and this, soaps where everybody is running about their health, that is not the situation. The reality, you have to remain calm, focused, and do what you have to do to get that child, well. So, yes, we encounter parents who are anxious, and it's like, you guys have been referred here, my child has to be operated on, and and you guys are now asking me a lot of questions. They are now taking blood sample and say you have to go to the lab, go and do X-ray and all that. All seem to be us wasting time, But in reality, we need to make sure the patient is stable before we can act. And we need to make sure we've dotted the I's and crossed the T's before we can take the patient into theater. So there are some situations that, yes, I've had a child who had grossly distended abdomen. He couldn't breathe. Just told the nurses, look, move this patient to theater. So right into the operating room, as soon as we got the knife on belly to just let the child be able to breathe, So we have those situations where, we hurry, but by and large. And then we're also not calm on our colleagues when we realize that the right thing hasn't been done.
Exactly.
I trained him. Well, I was part of those who trained him. And I'm sure he can recount situations where we come and we are breathing or screaming down their necks.
Right.
Why haven't you done this? Why did you do this? And all that, those incidents.
But how does it feel sitting next to him? Because, sometimes when you've taught somebody and they've actually gotten to the level, it's a blessing to even see them, right?
Yes.
Practicing effectively, masterfully, and so on and so forth. In terms of the what you've turned out, your fruits, some may think that you're a bit too stern, too stiff, right? But I tend to get fulfillment because many of them give you that regard and that respect, and suddenly it translates into something they've internalized.
That's right. So, we watch them work, and then you are satisfied. You are happy. We send patients to them because we know that you have trained him and he can deliver what you put in him. So it's a great joy to see yourself and multiplied. And within the past 2 years, God has been faithful. We've been able to churn out about 6 or 7 pediatric surgeons, So you are happy when you see your products and they are performing.
And they are in Ghana.
And they are yes.
Yeah. All right.
Well,
But again, some go out and they come back.
Two are from Gambia, and so they came to do their training here,
Okay.
and then they've gone back to Gambia.
All right.
Yes, but most of them, in the training pathway, when you get to a certain level, the chances of exiting is low. When you get to the point of training to be a senior, a specialist, senior specialist, a pediatric surgeon, then you know that there's no
turning back.
There's no turning back.
You just have to buckle in and finish. Good afternoon, Nortey. You are talking to one of the favorite doctors. I'm a pediatrician, so I can appreciate the love, the patience, and the commitment because our clients are simply magical. God bless their efforts. This is Jeremy in Pram Pram, all right, who says he is a pediatrician. Okay, now my mice are fighting each other. Nortey, please kindly help me to tell the entire pediatric surgeons and team at the Ridge and Children's Hospitals that God bless them beyond this life. These two facilities gave my two children another shot at life. I'm not getting a name here. Ooh, sometimes I scroll up to find your name. Please send your name to me so that the blessing is complete.
Amen.
All right, Nortey, can our doctors please help us with any emergency measures for a child who might have taken in any poisonous substance before rushing them to hospital for proper care? All right. Sometimes we are told to give the children substances like palm oil.
Hey.
I'm glad this has come up. Is it the right thing to do? This is Prosper from Dakuman, who probably has taken palm oil by force. But it's an important thing.
Nortey, let me jump in here because I'm involved with children who have taken in
A lot of
terrible poisons. So children, you know, a lot of children, I've come across a lot of children who have drunk caustic soda. And you know caustic soda is very terrible.
Yep.
It eats away your tissues. So they come with their esophagus blocked from the caustic soda they have taken in. Now, the challenge with this palm oil business when children swallow poison is that, one, you expose the esophagus to a second injury. Because when they take in the palm oil, they vomit.
Right.
So that acid or soda that has gone down,
Now
the
comes
vomiting
back.
brings it up, and then you get a second exposure to its corrosive effect. Number two, when they vomit, a lot of times they aspirate. So the vomitus goes into their airway, and then that causes another problem. So in a lot of situations, what they may have taken may not harm them, but the vomiting and the content going into the airway, into the lungs, is what ends up harming them. So they end up being intensive care, being ventilated. No, and so palm oil, no.
Capital N, capital O.
Capital N, capital O. Yes. So just take the child to hospital.
Right.
Period.
Do not administer anything.
No, don't administer anything.
Do not administer anything.
Do not administer anything.
Okay.
Take the child to
Just
hospital.
Take the child to a facility, to a hospital, right?
Yes.
Okay. Now, again, the reason I'm going through this because I've handled so many things that is amazing. But I do remember a child who had a fracture of sorts or fell down and had it bandaged at the hospital facility. I'll keep the details because of it went up to a complaint at Medical and Dental Council, and I even had to handle it on radio as well. But they go home after they've been seen at the hospital, and the child's hand starts to swell. Father says or mother says there was some argument over whether we should remove the bandage or not. And I think the prevailing decision at the end of that thing was to leave it and go back to the facility. Now, if I recall the details properly, when they went back to the facility, they reported, again, I'm saying reportedly, that the doctor said, oh, it's good you came, or otherwise this would have caused trouble. Okay? And so on and so forth. So certain things were done. But somehow the hand did not recover or whatever. Long story short, that child had to have an amputation. The arm was amputated. Okay. It went through the processes, medical and dental
That's
council, and so on and so forth. Didn't end too well, right? But I know there's a child out there with one hand or arm. Okay. In these situations that you've done a procedure, you've gone home, there's some discomfort. We talked about it briefly last week. There's some discomfort post-surgical intervention or whatever it is. Is it the same as what you just said, that no, go back straight? What would be the advice?
Every surgery has risk and complications.
99.7 FM.
I don't know what exactly was done for the child, but if it was a back slap that was done even for the child to keep the arm resting so as to get the swelling and other things done, it may have been, the fracture may have actually impinged on maybe a vessel.
Okay.
And sometimes as you are pulling the fracture to straighten the vessels and all of that, or maybe the vessel was already even torn. Right. And so that was what was seen as the swelling that had occurred rapidly around that time. And that may have been a complication of the injury in the first place.
Okay.
And maybe not even of the surgery. But every surgery has complications.
No, in this case, there was no surgery.
Yes.
Okay.
So, yes.
Yeah.
I mean, if you are talking about manipulation
Manipulation,
is
okay.
part of the whole
okay.
thing.
Understood.
Right. So every surgery has a complication, and there are risks to everything as well. So sometimes when the thing is done, what we usually insist on is to give the parents information.
Okay.
Information is very important because you need to let the parents know. And so one of the difficulties with our parents is that even as you are giving them the information, because of the fear and the things that they are thinking about, they are not really even listening to you. But it's very important to make sure that you are understanding everything that has been done, so that as you get home and anything happens, you rush back.
Okay.
Right. So information is very important, and when anything is done for a child, and even an adult, and you get home and you really realize that this is what is happening, it's better to get back so that something can be done about it.
My take on it is that, if I go to a shop, buy a TV, I get home, I turn it on, and it's not coming on. Sharp. I'm not waiting and say, tomorrow or they've closed. I'm going to see whether there's even a security person there to see whether my problem can be addressed.
Okay.
And so I always tell parents that if you get home, there's anything you are not happy about, just come back.
Okay.
If you go to a hospital, you are taken care of. And that word you didn't want me to mention, interception.
Yes.
People do a lot of hospital shopping, like window shopping.
Right.
You go here, you are managed, you are not happy with the care, or what you expect to take place hasn't happened. You go to another hospital, that doesn't happen. You go to another hospital, you go to another hospital. But go back to the same hospital. Let them know that what we did or what was done for you is not working. So they can think of the differential diagnosis that probably was not too heavy on the list, so that they can attend to you. So if you get a procedure done and you get home and you see the littlest of problems, just go back. I do a lot of circumcisions. Tell parent, if you get home and there is more than this amount of blood in the diaper, don't say I'm waiting till the next day. Come back, because you're supposed to run a 24-hour service, so that whatever problem there is, because that little time that you waste can actually result in significant catastrophes. And it's not surprising that was the situation in this patient.
Since you've mentioned circumcision, I asked Ade Farrakhan, and I used to ask Apiedu Mensah as well. So, do you have a telltale style?
Telltale style?
Yes, that if I see the child's penis, I know this was Dr. Trey.
99.7 FM.
Because some people feel it must look a certain way. It must come out this way.
It must look good.
Okay.
It must look good.
Who determines what looks good? Is there a cultural standard? Is there is the surgeon taught a certain way to circumcise?
Yes, we teach a certain way to circumcise.
Would it be different from maybe if a surgeon in Scotland, Edinburgh, or somewhere?
Oh yes, a lot. So we get these. I term them cauliflower type of P. I don't have to say the whole word. P, where there is excess skin around it, as though it hasn't been circumcised. And people fly their children down to get it revised. sorted. So it looks like the Ghanaian one.
Okay.
You know? Yes.
So is there a cultural element in that surgical procedure? Because if you do it, let's say, no offense to the UK, okay, I'm biased.
It's not only UK.
Yeah, but other places. Yeah. And then you come from here, and from what you've been exposed to, you're not happy, right? Is that just purely cosmetic, or it has?
It's purely cosmetic.
It's cosmetic.
Yes. Yes. It's not functional. It's purely cosmetic.
Okie dokie.
Yeah.
Right, 53 minutes past the hour of 2. I mean, thoroughly enjoying this. With some people, the clock just is my friend, right? We've talked a lot, but let's look at this issue of consent. If you were conducting surgery or surgical intervention for an adult, right? In many cases, the adult themselves or a significant other has given what we call informed consent for you to proceed. Now, in this case, we're talking about children up to the age, you said upper 18, sometimes 21, right? Yeah. What is the procedure, if we can quickly talk about that, for children? Is it the parents? Is it how is it done? Because there's a lot of challenge there, because they are already anxious and so on and so forth. Okay, you've come in as a professional. This is what you need to do, but I need your consent.
So consent usually for a child, I mean, as our constitution stipulates, would have to be given by the parent, or the guardian.
Parent or guardian.
Yes, that is taking care of the child.
Okay,
right, and so we focus more on getting that parent or the guardian who has brought the child to understand or have that information that is needed to be able to give that consent for us to get the child the care that the child needs.
Okay.
So our consent is basically for, unless the child is 18 years and above, then the child will now have to sign the consent themselves.
Right.
But by and large, we still, even though we are giving the parents the consent, for the children that can understand, it's really important for you to really engage them and let them also understand whatever is going to happen to them as well.
Okay. For a lot of people,
for that we say assent.
Okay.
So the child must know what you're going to do. And then agree also.
Okay. The whole area of medical legal issues. That's why I'm asking this. So for a lot of people, is this a signed document? Because it has come up and it does come up. So would you, the parent, be required to sign your informed consent?
Yes, the parent, for the minor, the parent has to sign the informed consent.
Okay.
We've had situations where a mother brings a newborn baby to the hospital. Clearly, baby is not able to feed because of this blockage, and then the mother says father must sign, and father is nowhere near the hospital to sign, and so we sit and wait.
Sometimes they say that because father must pay.
Yeah.
So then I try to go to hospital.
we sit and wait for whoever the guardian is, unless it is life threatening.
Right.
If it's life threatening, then we engage the hospital legal office. For them to come in, for them to give us the way out of the situation. So where it is not life threatening, parent, the guardian must sign and give informed consent before we can do anything.
Great stuff. 57 minutes past the hour of 2 on Joy 99.7 FM. About 3 minutes to touchdown for us. But let me bring this one in as well. Where consent is withheld, I will not consent. But you, as the pediatric surgeon, you know this child is in danger or this procedure is necessary, right? What happens there? And again, let me just stick in there, complicated a bit, but where the withdrawal is on the basis of religious grounds.
Yes. So and these come up.
They do.
Yeah. So we can discuss alternatives to the procedure.
All right.
If there's no alternative to the procedure, I mean, I've had situation a child came with the tummy was full of 2.5 liters of pus. And the parents said their family, nobody has had surgery, is not going to allow me to tag the child. He brought in his brother who was a lawyer, whether that was to intimidate, whatever. So we
to
talked
put it
through.
to you.
To put it to me. So we talked through it, and fortunately there was an alternate route. So we put in a tube and drained the pus, and what the child got well. So where the
issue there was the incision or the cutting.
The issue was the incision.
Nobody in our family has been cut, and therefore will not be cut.
That's right.
Whoa.
Uh-huh. So where it becomes is life-threatening, parents say they be that, and that is the only way out. Religious ground, whatsoever. The child is a custody of the state.
Okay.
Exactly.
So we get
Children's Act.
Yes, Children's Act. So we get the legal office to come in and then take us through. Yes, because the child needs that care, the child needs the care.
But the clock is ticking.
Yes.
Yeah, the clock is ticking, and sometimes that's where the problem is. The delay then results in significant complications, and then it's like, you people didn't do. We told we didn't want to have this done. You've done it, and now the complication becomes like that. So, the state is on the side of the healthcare providers as long as what they want to do is right, and that is the way to go by it.
Wow. And folks, guess what? You've had to do medicine for how many years? You specialized for how many years? And somebody brings this kind of contention where now it gets medical legal, but there's a life at stake. I'm just overwhelmed talking to these guys, these pediatric surgeons. I know I do this a lot with certain fields of specialty, but Doctors Trey and Asman, we salute your specialty.
Thank you.
And we salute the Ghana Association of Pediatric Surgeons.
Thank you.
I would love to partner you if there's anything you would want to highlight anytime.
Yes.
We will do our best on Ultimate Health to project that. And then for you, the parents, please, if you have any experience, testimony or whatever in the past, and I mentioned Ultimate Health started in 2003. I've collected many I've followed up. That's why I'm able to interject, right? Sometimes to your annoyance, I know. But
I know, it's okay. It's been a wonderful.
Right. So parents, please feel free to share with us at any time Ultimate Health. Children undergo and go through a lot. And there are a lot of miracle stories. And like I mentioned earlier, if anybody knows, Josephine Aipe should be a big woman now, a big girl now, right? It was a hole in heart, if I remember rightly. Intervention where radio got amazing results, all right? And maybe you're out there also, there may be something surgical that needs some attention. Send a message to us and we'll see if we can build a bridge. Docs, once again, I salute you.
Thank you very much.
Thank you so much for coming again. You know, this is reason for me to dance, eh? Hey,
thank you for having us. So this year, what our highlight actually was to get the public to understand what intussusception was.
Okay.
And
you'd love to come back to do that?
Yes, I think it's very important.
Okay. Just quickly, 30 seconds, just explain it. I'll bring you back to do that.
So that is, it's a state where the intestine, part of the intestine gets swallowed up by the other intestine.
Okay.
Right. And that is one of the one common thing that affects our children. And that also has a very good result if these children end up very early.
Okay. And
can also be very bad if these children end up very late. So we are really trying to highlight
one intestine is entering another.
One intestine is entering another.
Because of a hole or because of what?
No. So
just growth.
There are so many things. I think that when we
That's
get the
why
time,
you have to listen.
I will bring you back.
Yes.
Right.
Then so it's one of the things that we also want to get, because sometimes a lot of the children start getting some cramps, they cry a little, and then they stop, and then they come back, they cry again.
Okay.
And the mothers think it's okay, then they just go and give medications and all of that. We are trying to get some of these things done, because some of these things are very, very simple. You see a child that cries, comes again, cries again, and maybe after a couple of hours starts vomiting.
Okay.
You should know there's something really happening that you need to get.
I promise you will do it.
Yes.
Okay. I put my nose in the recently launched health intervention. I'll see. I may have to do a program on that. Okay. The primary intervention, primary care, and all that. Okay. I love to take a diligent look at these policies. We've had them in the past. For me, nothing is new, right? But interception, right? We'll come back and look at that. Folks, this has been Ultimate Health. Let me read this one. God bless you, Joy FM. This is very insightful. I've had my own share of kids swallowing stuff and keeping things in their ears, nose, amongst others. Hey, please name the kids. They are wonderful. So I was at work when I was called from my son's school that he had swallowed a battery, the watch type. Okay, they look like a coin. Yeah, flat. Okay, I nearly fainted, but I rushed to the school clinic, took him to the hospital, did X-ray, and I was told he would pull it out. It took 3 days, and gracefully it came out. You didn't tell us how you were searching and looking into the poo to make sure, right? I was so anxious and was taking daily X-rays until it came out. My son was 7 years then. My 2-year-old daughter also. Hey, this family put beads for her hair into her nose, but I managed to pull it out at home.
This is my son put
Nana
a bead
Ekua.
in the nose.
Let me celebrate her first. Nana Ekua Daniels of Tema. Ekua, I would love to meet those kids. Okay, but you know what? I'll come with an X-ray. You were saying something about your son?
My son also put something in the nose. So,
okay, yeah.
He knows children, they are very wonderful.
No, he knows daddy's a surgeon.
Joy.
All right, folks, I'm out of here. Many thanks to my surgeons. Stick and stay. Let's